for the invitation. I hope people are still awake. So I'm going to try and speak to you about red eye, how to improve assessment and referral to eye casualty for the patients who need to, because some you can actually treat in the community and do not need to refer to eye casualty. I'm sure the juniors would like that. So the aim of this talk is really to be able to differentiate between major causes of red eye and to know what's sight-threatening, which will require referral or urgent treatment, and what is not. I'm going to touch upon blunt and sharp trauma, and I also speak a bit about chemical burn. So when a patient presents to you with a red eye, you want to really ask yourself, is this a hemorrhage or a congestion? And if it is a congestion, is it localized or generalized? And if it is generalized, is it mainly more in the periphery, conjunctival congestion, or around the cornea, ciliary congestion? So if it is a hemorrhage, then the subconjunctival hemorrhage, also same thing, it's not showing. So this is a subconjunctival hemorrhage. Usually the patient wakes up from sleep and they find they've got a red eye, they get quite worried, they come to eye casualty or come to the optician. Now it's very important to notice that the posterior edge of this hemorrhage is apparent. So you want to really ask your patient 3 questions. Have they had any trauma? Are they on blood thinners? And are they on blood pressure tablets? If they are on blood thinners, you really need to inform the GP, because just as they can get a subconjunctival hemorrhage, they can get hemorrhage elsewhere in the body, so the GP needs to tweak their medications. Similarly with blood pressure, sometimes the blood pressure is raised during the night, so they may not be very well controlled. They may need to change their blood pressure medication to control the blood pressure, especially if this is repeated. And otherwise you tell the patient nothing to worry about, it will go by itself. And some people just have friable blood vessels and they will keep having repeated subconjunctival hemorrhage. Now, it's very different than retrobulbar hemorrhage, which is one of the absolute emergencies in ophthalmology. There are 2 absolute emergencies, and retrobulbar hemorrhage is one of them. So in these patients, that patient, you cannot see the edge of the hemorrhage, the hemorrhage under the conjunctiva. You cannot see the posterior edge of it. And this patient is not going to present to you by waking up from sleep and looking like that. They usually come in a major car accident or after maxillofacial surgery, major trauma, and there is other signs that you should look for, so like dropped visual acuity, proptosis, restricted eye movement, raised pressure, sluggish pupil. And this is really an emergency. So what you really need to do in these patients is lateral canthotomy. And if you are in a setup where, for example, in A&E, then we just open up the lateral canthus to allow the blood not to collect behind the globe and cause compression of the optic nerve and major blood vessels. And if you've done it and the patient doesn't need it, it's not the end of the world. We can always suture back the lids. But if you don't do it and the patient needs it, then they can really lose vision in a very short span of time. This is just to show you the example of subconjunctival hemorrhage and a localized congestion where the blood vessels are localizedly dilated in a certain area. Localized congestion can be due to episcleritis, scleritis, or a form of conjunctivitis which is allergic called flectinular conjunctivitis. Generalized congestion is caused by conjunctivitis, whatever the cause, or any corneal problems, uveitis, and acute angle closure glaucoma. This is an example of a localized congestion, and this is an example of a generalized congestion so that you can see the difference. So episcleritis, patients usually presents with pain and tenderness. It's usually not very severe, comes and goes, and very important test is to put a drop of phenylephrine 10%, ask the patient to wait outside for 20 minutes, patient comes back, and if this all is blanched, then this is episcleritis. Very different from scleritis. The pain is much more, can wake up the patient from sleep, a lot of tenderness on the eye, and it can come also with nodular form. Like if there is a nodule, you'll see the blood vessel is kinked on top of the nodule. So these patients have to be investigated because a lot of the times they may be associated with autoimmune diseases, and they are treated with NSAIDs, but most likely they may require systemic steroids to control it. Now, flectinular conjunctivitis is an allergic reaction to either staph exotoxin or TB exotoxin, and they come as little nodules on the sclera with localized congestion. They can also come on the limbus like this, most commonly in children, and treated by topical steroids. Now, what if you have a generalized congestion? You need to ask yourself a very important question: where is the redness? Is it mainly peripheral on the we call this conjunctival congestion, or is it around the cornea, which we call ciliary congestion? So conjunctival congestion is predominantly in the phonesis. It is superficial. The vessels are superficial, branching, and the color is bright. And you put a vasodilator phenylephrine, because these are superficial vessels, they will blanch. So this is an example of conjunctival congestion. And if you look in the back of the lid, you can see that redness mainly comes to the back of the lid. Very different than ciliary congestion. The vessels are deep radial because they are from the anterior ciliary vessels. They are dusky in colors, and they don't blanch if you put a topical vasoconstrictor. Can you see here? This is very different, and that's ciliary congestion. Now, conjunctival congestion, we said, is caused by conjunctivitis. Be it, there are so many different reasons for conjunctivitis. The most common is allergic, viral, by adenoviral or bacterial. Bacterial is very easy to exclude. So you ask the patient when you woke up in the morning, were the eyes stuck together with a yellow-green discharge? And if they say yes, that's your bacterial conjunctivitis diagnosed. You just give them topical antibiotics, and usually like to keep it for 2 weeks, even if the patients, after 1 week, they are feeling better and with no discharge. Viral and allergic is a bit sometimes difficult to differentiate, because in both the cases the discharge is watery. However, the allergic patients will come with itching and rubbing their eyes, while the viral patients will come with very sore eyes. Both of them have watery discharge, and the difference really is between the appearance. In the adenoviral conjunctivitis, you'll see these follicles mainly in the lower lids, and they are pale in color with redness around them, around the base, and that's because there is congestion. However, the allergic patients will come with large papillae, flat-topped, much bigger, mainly seen in the upper eyelids, and they are reddish because they've got blood vessels inside them, and there is scarring around them, and that scarring gives the whiteness. So exactly opposite to the viral. The viral patients will also have a pathognomonic feature, which is an enlarged tender preauricular lymph node. So for the viral patients, you give just reassurance, lubricating eye drops, tell them it will go away by itself, but stay away from everybody because it's highly contagious. If there are corneal signs, then you may need some steroids, but you don't want to give steroids to every patient because if it delays also the healing. But the allergic patients usually need topical steroids, and sometimes they need injection of subtarsal steroids if it's very chronic and we've got very big papillae. Now, this is another form of conjunctivitis, which is a neonatal conjunctivitis. You can see the yellow-green discharge and a lot of conjunctival congestion. When you get bacterial conjunctivitis in very young children, you probably need to give them IV antibiotics because they are unwell, they may be lethargic, they may have fever, so they really need to be referred and treated promptly. Now, chlamydial conjunctivitis is another form of conjunctivitis which happens in young sexually active males and females. And the pathognomonic sign of that is that it is usually unilateral. And if you give topical steroids to these patients, they don't respond. So that's why it's very important to diagnose. And we've got the swabs usually in eye casualty, and they will respond very well to doxycycline or azithromycin tablets. The patient and the partner both need treatment, and you need to inform the GUM team. Differential diagnosis of red eye is the pterygiums or diffuse keratoconjunctival proliferations, where you can see redness, and the redness is not because of an acute condition, but it is of a chronic condition and with a fibrovascular growth on the surface of the eye rather than congestion of the vessels in the conjunctiva and episcleral tissue. So ciliary congestion Ciliary congestion can be caused by anything on the cornea, for example, a foreign body on the cornea. So you really have to respect the patient's symptoms. So if a patient comes and tells you something went into my eye, you really have to examine the eye very carefully. And if you don't see a foreign body, you've got to really look for one, and you have to put fluorescein. And if you see these scratch marks, then do look for the foreign body, and don't forget to turn the lids, because the foreign body can be right on the back of the lids, like in this patient, quite often missed in eye casualty. Now, corneal trauma, a lot of children playing together, father and child playing together, quite often we see a laceration. Very important to stent for with fluorescein, and we do give them antibiotics to guard against infection, although there is not actually an infection. We can get a very nasty bug. Bugs can cause a lot of infection in the cornea, and these patients actually have to be admitted and treated intensively with intensive antibiotics. So you have to keep a very close watch on these patients, and they all have ciliary congestion, as you can see here. Viral conjunctivitis can be caused by herpes simplex or herpes zoster, and they have these dendritic patterns. So a patient presents with a zoster shingles like this one and complains from the eye, don't forget to put some fluorescein and check the cornea. Now, the other cause of ciliary congestion is iritis. So different signs of iritis, KPs, which you can see with your slit lamps. Now, if you've got chronic iritis or very severe iritis, you'll get this fistone pupil, because the iris actually sticks to the lens, and you try and dilate the pupil. The pupil is not dilated like a circle because it's attached at these points to the lens behind, and you get these pictures that tells you that the patients had iritis or have severe iritis, which require intensive treatment with topical steroids, and sometimes you give them subconjunctival steroids and dilating drops. Now, the third cause of ciliary congestion is acute angle closure glaucoma, and that is the second absolute emergency in ophthalmology. Patients present with headache, nausea, vomiting, reduced vision and halos, red eye, and the cornea is edematous and hazy, and the very, very pathognomonic feature is the fixed dilated pupil, and that's because of the iris ischemia. Unfortunately, that does not recover, and the patients will end up with a fixed dilated pupil forever. These patients, you really have to call the on-call team, wake the registrar up, put a cannula, and they have to be given IV Diamox or given IV mannitol to lower the pressure enough for the cornea to clear. Once the cornea clears, then you can do a laser iridotomy in that eye and also in the other eye, because the other eye is also probably is predisposed. And once the pressure, don't let the patient go home until the pressure is controlled. We really sometimes you give them treatment and send them home. I don't think that's good practice. You really have to manage, admit the patient, manage, and do the laser before you can send them home. So this is just to sum up. So red eye is either a hemorrhage or a congestion. Congestion either localized, caused by episcleritis, scleritis, or flectinular conjunctivitis. Generalized can be caused by conjunctivitis, and there are so many different forms of conjunctivitis, but if it's conjunctival congestion, it's conjunctivitis. Ciliary congestion can be caused by anything on the cornea, contact lens, foreign body, or laceration, or infection on the keratitis, or inflammation inside the eye, uveitis, or acute angle closure glaucoma. So all the causes of ciliary congestion are potentially sight-threatening. So if you see a patient with ciliary congestion, send the patient to eye casualty. So I'm not going to go through the cases. I'm just going to touch up a bit about trauma. So trauma assessment is very important. So you really, if a patient comes with trauma, you really have to assess every aspect of the eye, look at the lids, evert them, look at for any particulate matter, check the conjunctiva, is there a hemorrhage, is there a laceration? Sometimes conjunctival hemorrhage can mask a globe rupture, so that's very important, or can mask a foreign body. So if it's a sharp trauma, you really have to do an X-ray for these patients because you can miss a foreign body. Corneal abrasion, look for foreign bodies, laceration, ischemia, check the AC for cells, hyphema. Pupil may be dilated with mydriasis from the trauma. Dilate the pupil and check for vitreous hemorrhage. Check the fundus. Optic disc trauma does not usually give you optic atrophy straight away. It takes time to cause that, but you can also get retinal hemorrhages or commotio retini, or even a retinal detachment. These are examples of the foreign bodies, then again on the cornea or on the back of the lid. Now, what about blunt trauma? Can be used due to tennis ball injury. The eye is painful and red. You might find hyphema, like in this patient. Very, very important to bring the patient regularly to check the pressure, because if the pressure rises above a certain level, then you have to go and evacuate this hyphema. Now, other things that you can get with trauma is corneal abrasion. You have to cover these patients with topical antibiotics 4 times a day and review again in 48 hours to check that the patient's getting better. Now, penetrating injury is usually caused by a sharp injury. You can get probably an iris prolapse or a corneal laceration. Very important sign is the peaked pupil. So be very, very proactive if you see a peaked pupil, because that means that you've got a penetrating injury. These patients have to have tetanus toxoid if they've not had one recently. They have to have systemic antibiotics, and you try and send them for surgery as soon as possible. I don't know the video. So this is an example of the sharp trauma causing the peaking of the pupil, and sometimes it won't be that obvious because you've got hemorrhage, you've got subconjunctival hemorrhage, and it can be more at the limbus, but the peaked pupil is what gives away. This is another child with a penetrating injury, which was repaired actually in 24 hours. However, the child still developed late onset endophthalmitis. So that's just to tell you how important, if you can do it in the same day, it's much better than waiting. Now, just a touch on chemical burn. So chemical burn the worst is caused by alkali, being fertilizers, drain cleaners, or plasters, or cement, or even household cleaners. So that causes hydrophilic and lipophilic degeneration of the tissue, and that's why it penetrates deeper and deeper, and that's why it gives the worst prognosis. Acids, on the other hand, such as car battery or bleaches or swimming pool disinfectants, causes coagulative necrosis of the tissue, and that's the acid binds to the corneal tissue, and that it prevents further penetration. That's why the prognosis of acid injury is better than alkali burn injury. Alcohol usually just causes an ulceration on the surface. So chemical burn represent about 11 to 20% of ocular trauma. Young males have 2/3 of the cases, and alkali burn is about 2/3. Industrial accidents and home accidents and assaults are the problem. About 1,500 assaults cases a year is being documented, which is really, really very high. And the patients have symptoms come with pain, photophobia, blepharospasm, lacrimation, visual impairment. The first aid measure is really very important to irrigate. Now, because the eye is very painful, if you do not put an anesthetic, then they will be closing their eyes and the irrigation will not go in. So very, very important to put an anesthetic before you irrigate, and you irrigate probably with 1 liter of saline, and then check the pH before and check the pH after irrigation. And remember, if there are any debris, then that can continue to create problems and cause further damage to the eye. So you have to try and double invert the lids and remove any particulate matters, and then recheck the patient again after 10 minutes to make sure that the pressure is 7. And then there are other measures to reduce to change the pH, such as paracentesis, which we very, very rarely do, or injecting buffered phosphate solution into the AC, which I don't think I've seen that done. But it's very, very important to double invert the lids, as we can see here. And then to assess the patients, and there is many different, a couple of different gradings. So the better one, obviously, the DUAS classification for grading of chemical burns, because it doesn't only take the cornea into consideration, but also the conjunctival staining, and you have to check the patients and document exactly how much of the cornea is stained and how much of the conjunctiva is stained. And remember, a patient can look like that and you think there is no problem at all, but you have to put 2% fluorescein and wait and look for the staining, because for that although that looks not too bad, but if you stain, you'll find he's got complete limbal ischemia and absolute complete loss of epithelium. And this patient actually ended up with very, very bad results. It's very important to check the pressure. It can be low if you have got ciliary shutdown, or can be raised if you have got orbicular damage, but very important to check. And sometimes you can only check with your hands because you can't, the patient can't even open their eyes. How do we manage the patients? We give them preservative-free steroids 4 times a day, anti-proteases to prevent the melting, sodium citrate 6 times a day probably. Now the ascorbate level in the AC becomes less, so you have to give them oral ascorbate, so oral vitamin C, 1 to 2 grams per day. You have to cover with broad spectrum antibiotic, use cycloplegic, and remember not to use phenylephrine because already they've got ischemia and you don't want a vasoconstrictor. And anti-glaucoma, you want to probably use oral Diamox, not topical medications, because you don't want to bombard the eye with so many eye drops, which will be toxic to the surface. And then again, surgical intervention usually is late, except if the patient is not healing. You can put potential amniotic membrane, and if the whole ocular surface is affected, you can potentially put an amniotic membrane with a conformer and do a tarsorrhaphy to cover everything and let the eye settle. But otherwise, treatment to restore vision usually not before 18 months from the chemical burn, such as conjunctival grafts, stem cell transplantation. All of these are late managements. The hidden phases of ocular burns are bad and can have a devastating outcome. This is one of our very, very bad patients who's had severe alkali burn, and he unfortunately lost both eyes, although we tried everything for him. So to sum up, we need to recognize the sight-threatening causes of red eye, and any patient with ciliary congestion need to be referred to eye casualty. Superficial cornea aberration could be potentially treated with topical antibiotic with primary care, but do bring the patient back and make sure that it's getting better. Trauma, you have to refer depending on the visual acuity and the mechanism of action. Chemical burn, think of irrigation. Thank you.